Welcome back to another episode of Just Mental. I'm your host, Kendall, and for this week's episode, we have a very special guest joining us. We are interviewing Christy Gibson, a family physician from Calgary, Alberta. And before we go any further, I want to just put a trigger warning on this episode. We will be discussing MAid, which is medical assistance in dying, as well as trauma and components of trauma. If you don't feel that this episode is going to be right for you, we encourage you to come back next week. As always, we would love for you to join the conversation. Leave your comments down below. And if you want to be a guest on our show, you can do so by clicking the link in the description down below. So let's get into it. Why don't you start by just kind of giving me and everyone that's listening just a little bit of background into you. I know you're writing a book. You have quite a decent following on social media. So who are you?
Sure, yeah. So I'm Christine Gibson, or Christy, because what ended up happening is I was Christy in Facebook because I didn't always want my patients to friend request me because it's kind of a professional boundary. So I was like, okay, I'll just be Christy, because I was Christy for the first 20 years of my life. And so when I took a TikTok name, it just took my Facebook handle. I was like, oh, that's fine, whatever. And then TikTok blew up. I was like, oh, that's interesting. So now I have two professional names. So anyone who knows me as a doctor in Calgary calls me Christine. And then anyone who knows me from social media calls me Christy. So I actually published the book under Christy. And it was funny because I remember thinking why did I even change my name? Because I was Christy for the first 20 years, but it was this impression that to be a doctor, you had to be super serious.
Right.
And Christy wasn't a serious enough name. So I changed it to my actual name. And yeah, I've been a family doctor for over 20 years now, in Calgary, but also doing quite a bit of overseas work. So I've been running an international nonprofit since 2012. And here in Calgary, I created our residency program in health equity. So I got really involved in teaching doctors. I think 2008 was when we started that program. So we called it global health back then, but most of my students work in health equity here. So that's been my population practice for most of my career. I work now at the refugee clinic, adult addictions, but I've always worked with folks who are low income, or kind of just struggled. Now I know, because it took me a long time to recognize that almost everyone I work with was managing trauma, and I just didn't have the language for it because we had so little teaching about it back when I was in med school, and frankly, it hasn't improved a lot.
So, and by trauma, are you referring to medical trauma or mental trauma, or what exactly do you mean by trauma?
Yes, all of that. So the refugees will have gone through trauma in their home country, and then a ton of immigration trauma trying to get here, generally separation trauma. Most of my folks that I work with at the addiction clinic have a background of childhood trauma, or relationship trauma. And almost everybody, I haven't met very many patients who haven't had some medical trauma. And every doctor I know has medical trauma.
Right.
So the healthcare system is very heavily traumatized. And so I started off working part-time as a locum, just a substitute doctor in different people's practices when they were on vacation. And then I did a job called hospitalist, which was adult inpatient. And I did that for 17 years. And it was really hard. I was working 100-hour weeks. It was really not a normal job situation. And I just aged out. I just couldn't keep the pace up anymore. So I went into community and I started working at a couple of community health centers in the Northeast. And that's when it really solidified in my brain that the thing that I was seeing all day, every day in my clinic was trauma. And I had no skills with or very few skills at that time with how to deal with it. So this was 7 years ago. And then I just started learning everything I could about trauma. I studied with all the people I could find. I read every book I could get my hands on, and just got certified in lots of different modalities. And now I still do some family practice, but I mostly do trauma therapy.
I appreciate everything you're doing, as I'm sure a lot of people do. I actually didn't know much about, I want to switch gears a little bit, about MAid, until I did a little bit of research. It actually came as a a shock to me personally that because I found out about it when the changes about the mental health side of it kind of came into effect.
And that hasn't happened yet.
Yes, when it's supposed to be, is it April or May?
No, it was supposed to be March 17th, and they've actually asked for a delay. So we actually don't have any date or knowledge on when it is going to happen, if it's going to happen. So the federal government was supposed to, like, they'd asked for an initial delay. And so the delay was ending March 17th, and they asked for another extension.
Right.
So it may or may not.
And who makes those decisions in regards to?
It's tricky. So all of MAid legislation has come into effect in Canada because of patients. It's not government. So everyone keeps saying the government's trying to kill people off. I'm like, no, the patients asked for this. So the patients challenged their constitutional rights to an assisted death. And that was how the first MAid came about in 2016, is patients challenged their rights to MAid. And the legal system, the Supreme Court said, yeah, you should be allowed to have access to this. And then that's how the first MAid legislation came about. And then these changes to this legislation came about because patients are challenging the current legislation. So what started the ball rolling was in Quebec, they were working with the higher courts in Quebec, challenging the existing MAid laws and saying they're not extensive enough. So patients said, look, I should be able to ask for MAid if I have a chronic condition. And the judge said yes. And so the Supreme Court didn't challenge it. It just kind of went along and agreed with it. That meant that the legislation had to change to allow chronic conditions to be accepted under MAid legislation. But somehow they said that there were multiple cases that had to be sorted out one way or the other. And that included whether mature minors could apply. And so everyone is worried that that means kids are going to get MAid for mental health, and that's definitely not it. The mature minors situation would be kids who are palliative, kids who are dying from cancer and they're just suffering too much. So kind of the same way the original MAid was. And then the other two things that they were told they had to consider was advanced directive. So let's say you have early onset dementia and you're like, I do not want to get to the point where I can't recognize my family or I can't eat for myself.
Right.
I just don't want to be that person. Then an advanced directive would allow you to spell out the conditions where you would allow the medical team to do MAid with the family kind of overseeing that.
Right.
So it's kind of like a legal thing. And then the third thing that they were told that they had to sort out was MAid for mental health alone, because there was also some people saying it's discriminatory that you're allowing MAid for physical health conditions, but not mental health conditions because they also cause suffering. So all of the legislation in Canada has been patient driven. And I think that's one message that's been really hard to give people, because they keep calling it things like euthanasia and the doctors are trying to kill us and the government's trying to kill us. I'm like, I can see how you feel that way, but that's just not how it happened.
Right. And I feel I can totally see that perspective, and I appreciate you. That is a very, very, very big thing to kind of bring to the light, because when I was doing research on this, one of the biggest things that I saw was all in connected to how much the government is saving by enacting MAid, in terms of like how they're going to be able to save money with long-term care costs and all that sort of stuff. So the fact that, and I guess everything with the government kind of does come down to spending, and a lot of articles are written in that sense. But yeah, that was something that I had thought previously before hearing about any of this. So it's very interesting.
And that's a secondary outcome. So the legislation exists because patients challenge their constitutional rights. And so the whole reason that the legislation exists is because patients said to the court, look, we're suffering too much. There is a solution and you're not letting us have access to that solution. And so the courts were like, I guess you're right. And so these secondary outcomes are, health economists doing analysis on MAid. Where are the organ donors coming from? 6.5% of Canadian organ donors are apparently MAid cases, which I just found out recently. So that's a question that people are asking. People are asking about the costs of the MAid program versus the costs of not having MAid. Nobody chose MAid because it was saving people money. Like,
Right.
that would be weird and cruel.
So with that said, for those who don't necessarily know exactly what MAid is or what, obviously it gives people the opportunity to choose to end their suffering, but what exactly is the program? How does a person qualify for that? And what would the implications of having mental health criteria have on society or on our healthcare system?
Well, in your last question, we don't know yet, so I can make some like guesses, like I could presuppose some things, but the MAid process is pretty rigorous. So for you to apply for MAid, the patient has to apply for it. So doctor can't apply on their behalf, family can't apply on their behalf. They have to sign and have witnessed paperwork that they requested this thing voluntarily and that it's them who wants it. So that's the first thing. There's a lot of people who are saying the doctors are doing MAid on people. Well, no, you actually have to ask for it. And even in the cases, which is gross, like when somebody's suggesting it for whatever reason, even a suggestion doesn't mean you're on a list anywhere. A suggestion is just like, oh, hey, do you even know this is an option to you? And I get the perception that a suggestion sounds really disgusting from the other side, but for the patients who are suffering and they want to access MAid and they hadn't heard about it, they're quite thrilled to learn about it. So,
Right.
there's a spectrum of what that suggestion looks like. So first step is completely patient driven. We call that a record of request, and they request MAid. And then it differs based on each province. So I can only speak to Alberta, which we're both in. In this province, those requests go to a MAid coordinating team, and there's Southern Alberta and Northern Alberta coordinating teams. Generally, those teams are 3 nurses. Well, at least ours is in the South. You can also access the team by calling 811, or they have an email that's on the Alberta Health Services website. So it's fairly easy to access the team. They wanted it to be low barrier. Once they get a record of request, then they line up 2 assessments. The assessments are doctors or nurse practitioners who have MAid privileges. I think at this point, we all have to have done a training program in it. So we are aware of the law and people's rights and the ethical implications and all that stuff. And I have no idea how many of us are actually on the list of people that do assessments. And then of the people who do assessments, there's even a smaller number who do the provisions, which is actually carrying out MAid. The assessment is rigorous. I don't know how many pages it is off the top of my head. Oh, yes, I do actually. The assessment itself is 7 pages. And then once you like complete a MAid event, it's something like 15. So it's not a small document, and you have to document that they're making informed consent. So informed means they understand the implications of what they're deciding, and consent means it's an independent, freely voluntary wish on their part. So there can't be coercion, there can't be somebody who's benefiting from it. This can't be something that's imposed for any reason on the person. So informed consent is key. And then the other piece is that they're suffering, and they get to decide how much suffering is too much suffering. So are they having a loss of dignity because they can't do things that are meaningful to them? Are they isolated and lonely? Are they having pain crises or other kinds of symptoms that are just intolerable? And then that corollary is, have they been given the means to relieve those? And they don't have to accept those means. So like if, let's say you've got a patient with a cancer diagnosis, which is most of what I see, they don't have to do chemo, or they don't have to have surgery to qualify for MAid. They just have to be aware that it's an option for them. So it's kind of like, are they aware of their options, and have they chosen the ones that were acceptable to them? And if they haven't had access to options, then you have to do your best to try to get them access. And that's where the whole social stuff started coming in, is like, well, what if their issue is they're unhoused, or they don't have the finances to pay for their medications? And that's where things get really uncomfortable. And that's only been since track 2 was legalized, which was March 17th 15th of, I want to say 2021. I should check on that though. So from 2016, the only people eligible for MAid were people who had a palliative condition or a life-limiting condition, which is subjective. Like the person who's assessing, it doesn't have to be like, do you have less than 2 weeks to live, which is a hospice criteria. It's more like, would you be really surprised if this person died in the next 6 months? And it's kind of a gestalt on it. Like, just what's your impression?
Right.
You'd be really shocked that they died in the next 6 months. They probably don't qualify. And then track 2 was, do they have a chronic illness? And in that scenario, it's a different process. We call that track 2. They have to wait for 90 days after they've been approved to actually enact MAid. And in those 90 days, they're supposed to be accessing extra consults, other means to try to improve their life. So it's not like we just say, like, here's an open door, you can have MAid tomorrow. It's like, we want to do everything we possibly can to alleviate their suffering before they make this choice.
Right. And from my knowledge, obviously, this is a choice that can be changed at any time. If you decide, for example, tomorrow that this is what you want to do, you can get as far as the day of, and you can still choose. Nobody's forcing you to do this.
You can get as far as the second of. So I did 2 MAid assessments yesterday, and I'm very, very transparent when I say I can have the medications in the bag drawn up in the syringe. You can have an IV running, and you can look up at me and you'd be like, not today. And we just pack up and leave. Like, it is absolutely 100% patient driven. They choose the day, they choose the environment, except some hospices don't allow it. So the whole goal is to make the whole process very patient-centered. And I think the current narrative against MAid is people who haven't actually gone through it. Because people who've gone through it, I mean, obviously it's the families who are there, but the patients who've gone through it, they're so grateful, they're so relieved. It's such an amazing way to go. Like, I've seen horrible deaths in hospital, and these MAid deaths are so much more comfortable and connected to people they love. And it's actually a really nice process to be a part of. It's not weird and gross and all the things that are kind of said about it right now.
I think there is definitely a what's the right word? I think a lot of the stigma on social media comes from the fact that people don't quite understand. And you said it best, people who haven't been, it's like anything, especially with mental health. If you haven't been in that space, or you don't understand what it's like to go through those hardest moments, you can't try to understand what somebody is going through. I know that there is a very negative connotation surrounding this whole idea, and this was actually what you talked about in your TikTok video, but this idea that doctors are supposed to heal and doctors are supposed to help, and now we're giving them the power to do the exact opposite. Can you speak to that a little bit more?
I don't really think that MAid is harming people, because they get to say that their suffering is so great that death is a better option to them. So, like, yeah, I mean, we have this Hippocratic oath to do no harm, but I actually think a lot of medical interventions do harm. Like, if we're prolonging a person's life and prolonging their suffering, that does a lot of harm. And I think we lose sight of that, because, like, we're taught in medicine, like, keep the life going no matter what. And if you did, you've lost and you've failed at being a doctor. And I really think we need to redirect that, because sometimes you can do harm with interventions, and sometimes letting a person go is the kindest thing you can do if their suffering is so great that there's nothing that can be done to make them comfortable in this lifetime. So yeah, I wonder if I might have miscommunicated that intention. I don't actually find an ethical barrier when it comes to the existing MAid legislation. I feel very differently about mental health though.
Can we touch on the mental health side of things?
Yeah, for sure. The TikTok that I think I sent you after you sent the response was, I'm very much opposed to enacting MAid legislation for mental health until there is provision in every province and territory and access to adequate, acceptable mental health services to all people. So it's piecemeal through each province. There are some people who have almost no access, and the financial barriers are very much present if you want to go beyond the basics. So basics might be you could access a behavioral health coach, or you might access some CBT online, or you might get some text messages from some phone you call. Like, the free services can be helpful, but sometimes they're inadequate. And the stuff from my perspective that actually works for trauma, almost none of that's free. And you might have to pay $150, $200, $250 an hour to access the kind of stuff that actually works on trauma. That to me is unconscionable, that we would offer death before we actually pay for the services that work.
Actually just went through that process with seeing a therapist for the first time, and I don't necessarily, a lot of people don't have benefits either, but benefits don't necessarily cover all of it or a big portion of it, especially if you're needing to go once a week. Like, it's just not a feasible option even for me, and I would consider myself to be like stable income wise, and I still feel like it's a far reach to access the type of help that I would want to get. So you end up taking what you can, and a lot of the times that's not enough.
Yeah. It's really why I trained as a trauma therapist, because the people I was seeing who were dealing with substance use, who were refugees, they couldn't access the kind of therapy that actually works for trauma. They could access the baseline free stuff. And so my huge concern is that for the people who have significant mental health problems to the point that they would choose death rather than deal with their life, there are solutions for most of those people, and they just don't have access to it. And in some cases, they don't consider it appropriate. Like, some people just don't want to access psychological services, but most of them would choose that rather than choosing death, but they just don't even have the choice. And that's what really upsets me. At least in the case of palliation, we have pretty good coverage for palliative care and hospice. We have decent medical system for chronic illness. We do not have universal mental health care. And that's where I think we're making a huge mistake if that goes ahead.
So is that on, do you feel that that's on the government to enact new policies to help better support that? Or is that something within society as a whole that we need to do a better job of providing?
Well, and here's where we get to the problem, because the federal government enacts MAid legislation and the provincial governments are in charge of health services. So there's this disconnect where the MAid legislation happens at one level, some of it dictated by the Supreme Court, and then the provinces kind of get to decide so they get federal transfer payments, but they kind of get to decide how they run their health system. Right. So there's things that could solve it. The provinces and territories could make a commitment to supporting universal access to good quality mental health care and pay for the things that are actually beyond CBT and a couple of DBT groups. Like, those are helpful, but there's so many more layers that can't be accessed for people. So that could be something that could be universally agreed on, or the federal government could make transfer payments to the provinces and insist that these payments are for mental health services and that they have to widen their access to what's freely available to people and make it accessible culturally, language, regionally, like make sure everyone who's in rural areas or underserved areas can get it. Make it culturally appropriate care. So make sure we're training lots of, BIPOC folks and Indigenous programs that consider Indigenous worldviews. Like, there's so many considerations that have to happen, and it could happen at either level, but that has to happen first.
No, that makes so much sense. And I think that there's a lot of people out there that I've seen specifically that have wanted to get help, but again, the inaccessibility aspect of it is hard. And I can see why, as a doctor, I don't think that any normal person is ever going to see, to the extent that you see, how this is affecting society, specifically those who can't access proper mental health resources. For somebody who can't access those resources, is there something or someone that they can go to that can offer a better support system versus the free resources that are currently available?
Well, I mean, no, this is really all we've got. We've got Access Mental Health in Calgary, where you can get on a wait list for mental health services, and patients can actually self-refer to Access Mental Health. You can get, just calling 811 will actually help you figure that out. And I think 211 is social services. So 211 would be another roadway in. So 811 is HealthLink, and 211 is like what services are available in your region, including mental health services. Some PCNs, like primary care networks, offer mental health support, and that could be a psychologist or it could be a behavioral health therapist. So depending on whether your family doctor is a member of a PCN and then which one. But then again, that gives you piecemeal coverage, and everyone's going to have inequitable coverage. And what I want to see is everyone having access to all of the things before we would allow MAid to be on the menu options. Like, I think MAid as a menu option makes sense to me, but unless you have other options on the menu, that's when it becomes problematic. So in the case of chronic illness, in the case of palliation, there's other menu options. In the case of mental health, it's pretty restricted. You might just have an appetizer and then we're going to add MAid to your main course. That's just unethical in my view. So no, I mean, the reason I joined TikTok and the reason I wrote a book is because I wanted to try to get more mental health tools in people's hands. And some of the stuff that I teach on TikTok and like distinct chapters of my book are like how to regulate your own nervous system, how to get your nervous system out of trauma responses, because these are basic tools that should be taught in school and taught to every doctor, and they're not yet. So I'm trying to work at that systems level. So, you know, having been a doctor for 20 years, I started studying social innovation and design theory. And I realized that there were other points of leverage where I could make an impact on systems. And like, you could join the government and try to be like, you know, making the medical decisions for what the government does. Jane Philpott did that at the federal level, but it didn't work out very well. She didn't get to do the things that she wanted to do. And so when I was trying to think of, well, how can I make an impact at systems level? Social media and writing a book and getting the information to people's hands were the things that I thought was possible from my end, because most people can't access this.
Just touching on that nervous system kind of bit there, what should a person know? Because obviously, I think anyone that suffered with mental health has been down the route of going to a family doctor, being diagnosed sometimes, I guess, and then being prescribed medication as opposed to seeking out natural ways like talk therapy. How can what you're teaching people help either support medication routes for treatment or completely replace it?
Well, and medications don't work for trauma. That they just don't. So medications can work for anxiety or depression. Psychedelic medications work for trauma, but we actually don't have anything in our toolkit as physicians that are saying that's going to cure your PTSD. We can put band-aids on it. Like, we can give people alpha blockers and beta blockers that calm their heart rate and blood pressure so you don't feel like you're having a trauma trigger, but you're still having it. Like, the pathways in your brain are still there. So from a trauma perspective, like, medications actually won't work. For depression and anxiety and things like OCD or somatization, medications can work, but they don't work for everybody. And when they do the studies, therapy can work equally well to medications. And you mentioned talk therapy. Again, that only works for a certain percentage of people. So a lot of the work that I do is body-based therapies. And I do a lot of the eye movement treatment called accelerated resolution therapy or brain spotting. And those work on subconscious foundational beliefs, which talk therapy doesn't get to. Right. So what I'd love is for people to have all of these things on their menu. What if you could access somatic treatments? What if you could access the eye movement treatments, whether it's EMDR, accelerated resolution, or brain spotting, and also access the whole gamut of talk therapy. So CBT is the one that we generally get access to, People with certain diagnoses might have a doorway into DBT, but there's ACT, acceptance commitment therapy. My absolute favorite therapy is called NARM, neuroaffective relational model. There are so many things that we should be putting on people's menus before we put something like MAid on the menu.
I 100% agree. I think the biggest issue with our healthcare system is that there is inaccessibility. And I think a lot of the times there is still that stigma that trying to get help is weak or not looked at as something that you should still be trying to do. I personally was extremely embarrassed to go to a doctor. I didn't think that there was anything wrong with me necessarily, which there isn't.
You froze there, so I didn't hear what you said. Can you say it again? You
Yes.
said something about the stigma.
Yes. I still believe that there's a huge stigma around mental health and the process of getting diagnosed as well, which is something that, I mean, it's going to take a long time to break that down. But is there anything that you feel we could be doing better to help break down those barriers besides accessibility to treatment?
It's tricky. Like, if I'm totally honest, I'm not a huge proponent of the existing diagnostic codes. I think it puts people into boxes that they don't necessarily fit because I now understand trauma. So I think a lot of people who are diagnosed with autism, ADHD, anxiety, depression actually are having a nervous system response to past experiences. And if you can change the nervous system and rewire the brain pathways, those symptoms will disappear. So, like, when the DSM, or like the big book on mental health, was created, it was a bunch of old, mostly male psychiatrists getting together in a room and saying, well, there's this symptom complex, this symptoms that kind of bunch together, and they would just debate what to add in there. It wasn't really an evidence-based document. It never has been. It's been subjective from a psychiatry perspective, not a patient perspective. So I know that diagnosis can support a patient in feeling validated. Oh, like there's something wrong, like there's something happening in my brain that needs help. And it can also help them find community. Like, they can Google online support, they can watch a lot of social media posts and learn more about that condition. So I'm not saying we should altogether stop with any labels, but I think that the labels should be really loosely applied and saying, you've got symptoms of depression. Let's find out if this is a nervous system response or if there is a chemical response. Like in 2022, there was a research paper showing that serotonin may or may not even be the issue in mood disorders, which is something that, you know, for 20 years I had learned was the case. So do SSRIs or medications that are supposed to put more serotonin in your synapses, do they have other means that they're working? Or is it placebo effect? Placebo works 30 to 50% of the time. It's super powerful. There are so many things that we have yet to unearth in the field of mental health. And I'm really hoping that we can have a huge paradigm change where it's patient-centered and the community is telling us what changes to make, and that we recognize the role of trauma in all of the mental health presentations that we're currently seeing. So those are two foundational shifts I'd like to see. And it's another reason why I wrote the book, because the stuff that I put in the book is nothing I learned in medical school. And I think every doctor needs to read it.
What would be your response to somebody saying something like, it's all in your head, or you just need to think positive?
Yeah. Two different things I'll say. The it's all in your head camp is just flagrantly untrue. We have serotonin receptors in our gut, and our gut microbiome, so the bacteria that lives in our bowels, affects your mood. In fact, here in Calgary, the department head for psychiatry, her research is taking microbiome flora, so bacteria that live in your intestines, encapsulating them into a pill form and having people take them to affect their DSM diagnosis. So if you could control your mood by controlling the bacteria in your intestines, clearly it's a mind-body system. So there was a time hundreds of years ago when a man named Descartes, who was like a philosopher, tried to separate the mind and the body. And a lot of medicine kind of stuck in different body systems. So psychiatry or neurology gets to deal with the nervous system, and then every other thing has its own little silo. It's why I liked being a family doctor, because you actually look at everybody as a comprehensive whole. And in modern psychiatry, most people understand that. So you could have a nervous system dysfunction that is keeping your sympathetic nervous system activated. And the way that a person experiences it is through anxiety, because when your sympathetic nervous system is activated, it means your heart's pounding, your mind's racing, your muscles are tense, your skin's clammy. And every single mental experience is your brain getting those signals from your body about what your body's up to. And then it creates a perception. It says, oh, okay, I must be feeling this way. So emotions are made in the brain. They're created based on the physical sensations the body is sending. But it's the same thing. So like people will present with, an adrenal tumor or like certain kinds of neurotransmitter tumors with an anxiety syndrome. And it's all because they're interpreting this elevated heart rate as, oh gosh, I must be really anxious. So when we think of what the brain is doing, is it's perceiving the signals it's getting. Likewise, when you have a really slow nervous system, like, I don't know a lot about the condition that they call adrenal fatigue, but I will say people are exhausted and stressed out and kind of done. Like they're just overwhelmed. They're working and they're dealing with family and they're trying to stay healthy, and they just have all these things on their plate and they get overwhelmed. They're not getting enough sleep. That underactive nervous system can lead to a sluggish feeling and a sense of paralysis. And so until we really recognize that mind-body syndrome, and how it's constant communication between the body and the brain, and we can't actually separate any of it out. So is there a process that's going on in the system? Yeah, but there's nothing. That's all in your head.
It feels really good to hear somebody with your background speak to that, because I've heard it way more times than a person ever should hear that. And I know there's tons of other people out there that have also been told that. There was actually, I saw a quote and a tweet from somebody who has quite an influential power over a lot of young people. And he basically just said that your mental health is completely in your control. And all you have to do is just think positive thoughts and go take a walk. And that was basically the premise of this tweet. And for somebody who has struggled with mental health, it never feels that simple. And it never is that simple, from my experience anyways.
No, you're absolutely right. I mean, if it was that simple, people would make that choice. Nobody wants to suffer from mental health symptoms. So it's gaslighting to say like, oh, you could just be making different choices by thinking better. And it's one of the reasons why I'm a little hesitant to recommend CBT to everybody, because that could feel like gaslighting. It's cognitive behavioral therapy, and you're looking at like, well, what's wrong with your thinking? The therapy I love much more is NARM, neuroaffective relational model. And the question that they ask is, well, what's right about your thinking? Why does your thinking patterns have this assumption of these foundational beliefs? How was that thought process adaptive for you? Like if you were a kid who was constantly told that they had to be a certain way in order to earn love and acceptance, you're going to become a very people-pleasing adult, and you will push your own needs down. So in CBT, they would try to say, well, what's wrong about that? Like, why are you ignoring your own needs and not setting boundaries and people-pleasing? And in NARM, they'll say, well, what's right about that? Why is that adaptive? And how has it worked for you in the past? And I much prefer that second line of thinking. So when you say like positive psychology is just think different, part of it is being like, well, why do I think the way I do in the first place? And how has that helped me? How is that a survival strategy that this mind-body system adopted to get me through tough times? What about it's working? What about it's not working? What about it is going towards the goals that I have right now? And that's the way that I kind of like talk therapy going. It's kind of an awareness that you have more options available to you, but it's not necessarily control, because everything that your brain does is adaptive. It's adapting to painful past experience. It's adapting to relational trauma. It's adapting to stuff that you've been through with people who are facing trauma because they're racialized or they're in an LGBTQ two-spirit plus community. Like, just being in the world, being neurodivergent in the world is inherently traumatic. So when you say like, oh, just think better, like that's gaslighting those people who actually have traumatic experiences on the daily.
When I first went to therapy, I'd been to a therapist before. It was not a great experience, and I went to another one. And what you say about childhood trauma, she also mentioned that to me, and saying that a lot of people don't realize that why they struggle or have certain struggles in life comes down to how they were raised and the influence that their parents had on them. And I think that's a really big thing, because I grew up in what I thought was a very normal household. And when you get down to the root of some of the stuff, I grew up as a very competitive athlete, and a lot of the love, obviously my parents, I know they love me, but it was shown majorly through success. And so when somebody pointed that out to me and said, this could be part of the reason why you feel like you always have to be on your A game 24/7, it's shocking to hear that a lot of that comes down to your childhood. It really is, especially if you've never heard that before.
Yeah, I didn't understand it either. And especially when I was a doctor and I was like, how could your asthma connect to your childhood? But the thing that made the connection was a study in 1999 called the ACEs study. So a doctor named Vincent Felitti was working as an internist in California, and he was working with people who were trying to lose weight. And what he was recognizing is that some of the people who did an amazing job at weight loss quickly regained it. And he started interviewing them to try to figure out what was underneath it. And I don't want to say something that's too triggering, so I'm going to shorten the story here, but say that he uncovered some pretty significant childhood traumas in those patients. And once he made that connection, he said, well, let's find out how much of this actually applies to the greater population. So they did this public health survey where they sent this survey to 17,000 people in the Kaiser Permanente group in California, people of all walks of life. And they found out that tons of them had had adverse childhood experiences, or ACEs. And they'd only asked 10 different experiences on that survey. So there's more that they didn't ask about. The numbers would have been bigger if they had. Of those 10 things, every single experience that a kid went through exponentially increases their risk of every single medical condition, mental health condition, and social condition that we've ever known of. So people with high amounts of adverse childhood experiences will have cancers, they'll have heart disease, they'll have diabetes, they will be more likely to have teen pregnancies, they will be more likely to be unhoused, they will be more likely to deal with depression and anxiety and other symptoms. And obviously trauma, complex trauma, PTSD is underdiagnosed, but it's underlying a lot of this stuff. So this is another thing that helps us understand the mind-body connection. If childhood experiences correlate to every single disease we've ever heard of, there's clearly something that's happening in the mind-body system to get from here to here. One of those things is epigenetics. So we always thought, I mean, I studied genetics in my undergrad, and we were taught that you inherit this DNA code and it shows up in your nucleus, and it's the blueprint for the baby and it's a blueprint for the adult. And what we now understand is it's actually just a suggested blueprint. The thing that decides what part of the blueprint prints is the cell wall. And it's what you're exposed to. So it's what you're exposed to socially, chemically, relationally, what inputs the child has. Like if a child isn't held at a certain age as infancy, that child turns out completely different than a child who has physical touch. These are epigenetic changes, and awfully, they can be passed down. It's one of the causes of ancestral trauma. I didn't learn any of this stuff in medical school. And part of it is because I'm old enough that the study came out after I'd graduated, but I should still have learned about it. Like I do all kinds of CME trainings. This should have changed everything that we studied in medical school, because it means that trauma is the greatest risk factor for everything. It trumps diabetes, it trumps smoking, it trumps weight, it trumps everything. And once we make that connection between mental health and wellness, then we would be putting way more resources into it, especially around childhood. And I firmly believe that parents are doing the best they can. I mean, every generation of parents is trying to learn a little bit better. They all have their epigenetic traumas and their ancestral inheritance. And there's different schools of thought on parenting. So like a parent who's really like success driven is like a tiger parent, you know, somebody who's kind of measuring these expectations. We've now got these helicopter parents that are never letting their kids out of their sight and make independent decisions. Parenting has these kind of ways that we try it every few decades, and they're just doing the best they can with what they're hearing about how they're supposed to parent and what their parents did for them, and they're going to try to be better than that. If they had childhood abuse, a lot of parents are totally dissociated and they just have very superficial interactions because they are so disconnected from their kid. They're doing the best they can.
I didn't know, and it's crazy to me that nobody is being taught this. I don't know, have things changed for new medical students coming up, or is this still?
They get like an hour lecture in it. It should be permeating all of the modules. It should be like a pervasive theme. So one thing that I know they're changing is like the whole Calgary medical curriculum is going to change and be more trauma informed and be more aware of this. So there are groups working on that right now. But yeah, I mean, up until last year's terms, they would study communication, but the way that a doctor would talk to a patient wasn't embedded in trauma informed practices, right? And we need to be making that link at every step. And it just causes trauma both to the patients and to the doctors if they don't. So I'm hoping that there's going to be big changes. Time will tell.
I think it makes a ton of sense. I mean, even after seeing the therapist and having her say that this was potentially a lot of the problems that I was experiencing now are due to the ways in which I received love and how I've grown to continue to try to get them. It's so subconscious that you don't even realize as an adult that you're doing those things until someone tells you, hey, by the way, have you ever thought about why it is that you can consistently try to strive for success, even if it's unattainable? And I find that extremely interesting. And I don't think a lot of people know about it. I honestly don't. We're always told to look at everything else, all the other symptoms that come with it, instead of looking. No one ever thinks that their childhood necessarily, even if it, especially if it was a good one, could have the effect that it has on you as an adult.
Totally. Yeah. And if it's a bad one, then even more so. So, and good and bad is totally subjective. I mean, you can have two kids growing up in the same household and they have totally different experiences of the parenting relationship and the way that they feel about their childhood. One example would be Prince Harry and his brother William, right? They grew up in technically the same household and they feel really, really differently about that environment. I just had to give a comment about that to a news outlet. So it's subjective, like it has to do with both your inner workings, like the personality you are born with and your own innate strengths and resilience. And then it has to do with the experiences that happen to you and around you. And your foundational beliefs get put down at a really young age. Like some of them even happen pre-verbally. So Gabor Mate talks a fair bit about this, but like as a baby, before you even have language, you're laying some of those foundational beliefs about, is the world safe? Can I trust people? And as an adult, you have those beliefs that you carry with you, but you don't even necessarily have the language to associate why you have those thoughts. So let's say, like in his case, his mother was separated from him at a key time. Let's say a kid is adopted, or let's say a kid has a mom who's experiencing postpartum depression. All of those things will lay down some foundational beliefs before they have language ability that will change the way they perceive the world as an adult. How can you do talk therapy to interfere with that? It's this thing that's just stored in the tissues. So a lot of trauma books are called The Body Bears the Burden, The Body Keeps the Score. Like we hold these things in the mind-body system. And then we just work on the brain, we can unearth some of it, but those really early foundational beliefs, they're not even accessible, not in a language form.
I think that's really interesting that you touch on um, Prince Harry. I'm actually reading the book right now,
Oh,
and I find
cool.
it absolutely. I watched the documentary, and I was one of those people that was kind of, I fed into the media quite a bit in terms of how they were presenting Meghan. And so to see her side of things and see how she experienced all of that, and then hear Harry's side, it's, you would think that this royal family is this amazing experience that these kids got to have growing up, and to see that that's not necessarily the case is, I think it speaks a lot to how and what we're shown as a society in terms of appearances being a big bulk of everything, and also that, I mean, their mental health was not really a priority at all. It was more about, again, keeping up appearances. So, yeah, it's very interesting. That book is, I would recommend it. Have you read it?
I haven't. I'm gonna read it as an audible because I want to hear Harry's voice say it. So it's on my list to buy as when my audible comes up next month. But I did watch the documentary, and for so much of what I was watching, I was like, oh my gosh, this is trauma. Because it's so easy for me to make that connection now. And on both of their ends, they went through tremendous amounts of trauma. I mean, the things that were said about Meghan in the media are vile and violent. And for her to have been told that she's supposed to accept it and not try to like protect herself, I mean, I just felt this visceral reaction to what that message was. And I think one of the good things to come out of this, I mean, I'm hoping their lives are better. It looks really sweet with their farm animals, and, you know, I'm hoping their lives are better. But what I love that they're doing is they're opening this conversation on mental health. And they're really addressing mental health and letting people know that it's okay to talk about this. It's okay to know, you know, when she talked about having thoughts of unaliving, most people don't talk about that stuff when they're in a position of privilege. And I think it's great when we validate it and normalize it and say, anybody can go through it. You can have certain kinds of privilege, because Meghan had social privilege as an actor and financial privilege joining the royal family, but she lacked other kinds of privilege, including, you know, the ability to be authentic and to actually be the person that was having these experiences. But as a Black woman, she lacked a lot of privilege in that, those interactions. And I think, even as you're saying, like, you can have some privilege within a family where, you know, you got your needs met, you were fed and clothed, and you had bedtime stories, but there's other kinds of privilege and experiences that we're missing. And I think a lot of people think of childhood problems as abuse, but there's also neglect. There's also things that didn't happen. So if you weren't accepted no matter what unconditionally, that's something that didn't happen. And I think when a lot of people look at the lens of what did happen and also what didn't happen, they can see, well, I have certain kinds of privilege, but other kinds of experiences I just never got. And that's affected me in these ways. So yeah, I mean, I think everybody should be in therapy, honestly. And that's one of the things that drives me, you know, to do what I do, is because it's not accessible. It's not called universal healthcare. And we all know the mind and body are so intrinsically connected. The mind can actually create physical symptoms and vice versa. So how are we saying that we're going to treat physical health and you can have access to these specialists, but you can't see a therapist for the stuff that's also interacting with all of it? And we've just made these false dichotomies in our universal care system in Canada. And it's something that we really need to backtrack on. And I was glad to see that the NDP had said, like, we need to get dental care into full body care as comprehensive universal care. But I really wish someone would say, what about mental health? Because, you know, pre-pandemic, we had at least 20% of people having active mental health issues and at least a quarter of people having mental health issues throughout their lifespan. Post-pandemic, I'd say it's more than 50%. Like, it's really, really high numbers. And we have this new epidemic. and absolutely nothing to do for people. We're saying like, oh, go take a yoga class or take a walk or think different. That's not what's going to solve these problems.
It's much more of a systemic issue as well. In kind of, I like that you said that we need to connect the mind and the body, because I feel, I mean, I'm blind. I don't have very good eyesight, and I've always wondered similarly why the government doesn't consider your eye health to be part of universal health. I mean, it's not covered, it's very expensive. And if you think of it that way, it just, from a holistic perspective, it doesn't make sense why it wouldn't be included. So
Yeah.
I think that's part of the reason why we like having these conversations, is because somebody needs to start talking about it. Otherwise, nobody's going to. So I commend what you're doing on social media as well, because I think you're able to help a lot of people simply by showing up and doing what a lot of people won't.
It took some privilege on my part, like for me to have 20 years of experience and to take the amount of time that it took me to learn everything I did about psychology and mental health. Like I basically earned a whole degree without getting the degree. So I'm now actually doing a doctorate based on that, because I was thinking, like, I've read 300 books. I'm certified in like 10 different things. How is that doesn't give me letters behind my name? There was a lot of privilege in being able to do that. And so because I had that privilege, I was kind of like, well, how can I distribute that? How can I get the word out about all the stuff that I learned? So, I've got a TikTok channel. I'll announce to you that I'm going to be starting a YouTube channel with like book reviews about mental health. And my book, the Modern Trauma Toolkit, is very accessible. Like we tried to have it be at a grade 8 language, so anybody could read it and understand these really complicated concepts. But I go deep. I talk into parts of your brain and how they work. I talk into how the DSM works and how different things that happen both in your childhood and your lived experience, but also in the environment around you, change the mind-body system. And then the second half of the book is body-based solutions. So I'll teach people tapping, havening, tremoring. Like I want these tools in everybody's hands so you can regulate your own nervous system. And then the other part of the book is, how do you influence society? How can you make changes at the community level? So I talk about things like design thinking and how can you influence policy? Because we can't just work on the individual body if we keep getting harmed by the environments that we're in. So I think the conversation has to happen both in healthcare, but in so many different environments, in work environments, in families, and schools. We just need to be talking about this way more.
When is your book going to be available for people to purchase?
So it's available for pre-sale now. It's on the Amazons, and I actually looked at Pages, which is the bookstore at the end of, my neighborhood. And that's where I get all of my books. And because it got like an ISBN, I think is the number. It's like a library code. They can order it. So literally any bookstore planet order the book. It's on the Amazons, and including the audiobook, which I just recorded last week. And I thought it was really important to have a slow and soft voice. So even though I'm talking really fast in this podcast, this is not how I talk in the audiobook. It's very slow. It's very comforting. It's very soft. It's a good landing place. It's not something that's going to trigger most people. It's something that should be easy, for somebody who's got some visual impairment to digest.
Amazing. Well, again, I really appreciate you taking the time to come and talk. I've learned a lot just in the last 45 to 50 minutes of talking, and I really appreciate everything you've been able to share. I think with the right voice and the right message, we can definitely bring more awareness to what needs to change within our society to make mental health more accessible. And that would be ultimately the dream goal for sure.
For sure. Well, thank you for having these big conversations, Kendall. I'm glad your voice is out there too. And I'm glad that you're, exploring your own therapy. I have 2.5 therapists. Like, I really think it's something that everyone should access, and it would change the whole world if we could.